Hi, everyone. It's my pleasure to introduce our next speakers, Leslie Leach and Paige Davies. Leslie is a public health nurse of 23 years. She's a certified in infection control and is an IPAC specialist supporting long-term care homes, retirement homes, and congregate living organizations through the Southwestern IPAC Hub. Paige Davies is a nursing student from Western University working with the infectious diseases team at Southwestern Public Health. So just a reminder that their presentation will be recorded and slides made available to you following the workshop. Please feel free to add your questions to the chat, and Leslie and Paige will take your questions at the end of their presentation. And with that, I welcome Paige and Leslie.
There you go. Thank you very much for that introduction, Kelly. And Paige, you've got the slideshow mode. Excellent. Appreciate that. Again, thanks everybody for your time. I know we have lots to do with very little time to do it in, so your time is much appreciated and valued. So the title of the presentation is IPAC Basics, or Infection Prevention and Control Basics. And we know that something new has been developed by Public Health Ontario, and they now offer an online IPAC education course for non-clinical staff. Some of our group homes, some of our other congregate settings do have clinical staff, and you're very well versed in a lot of the things that I'm going to talk about, but there are many settings that have support staff that don't have that clinical background. And so the course was designed for those that don't have that formal healthcare training and work in the congregate living setting. It's intended to provide learners with infection prevention and control knowledge to keep yourselves, your clients, and your coworkers safe from infections in the workplace. And like we heard from Dr. Tran, this season that approaches us, it's more important than ever to be ready and able to deal with what comes through your door. So if you decide that you want to take some additional education and information on IPAC, some of the topics they will cover are risk assessment, performing hand hygiene, when and how to use personal protective equipment safely, and also outbreak management. We will be covering very briefly a lot of that in this particular presentation, and I know Robin, who follows, will be covering the outbreak management. So I do encourage you to look at the Public Health Ontario website if that interests you, for not only your own education, but for your staff and visitors as well. So I'm not sure if everybody is familiar with the chain of infection, and different artists have a different rendition of it depending on the source you're looking. This is kind of a friendly version, and we borrowed this from Public Health in Ottawa, but we've certainly seen it more chain and fence-like. And so that's what the comparison is going to be today. So this chain, in order for someone to become sick or develop an infection, all of the links in the chain of infection must be intact. An infection can be prevented by breaking any link in the chain of infection. And the infection control measures and practices that are in the guidance document, that are shared by public health or other ministries, are intended to break the links, thereby preventing an infection. And so you will see that there are 6 links in front of us. The first link that we're going to look at happens to be the germ or the infectious agent. And so some examples, include bacteria, viruses like COVID-19, parasites. And I'm just wondering, just to get everybody participating a little bit and thinking in the chat box, if you can just name one infection or germ that you're familiar with, other than COVID. Because we all know that we've said that word so many times in the last 2 years. So any type of bacteria, virus, influenza, streptococcus, strep pneumo, very good. MRSA, methicillin-resistant Staph aureus, good. So those are all germs that we're watching out for. So the next link in the chain is the reservoir or the place that the germs live. So examples where the germs live are people, the environment, the food we eat, pets. And so building on this example, just wondering if you can share anything in your practice, your homes, or your teaching, something that you have introduced to break this link. So how have we been able to look at a reservoir and break that link? And whether you do that now or whether we continue to talk and something comes to you, not only do we need the germ and the place that it lives, we also need a way for the germ to leave. Good. So examples of how the germs get out, like COVID, if we're going to continue to use that example, is through our mouth, through coughing, sneezing, spitting while we sing. Germs can also leave through surgical wounds, skin, through our bottom when we use the toilet. And again, looking at ways to prevent this. And so part of the universal masking that's been implemented across the province and in these vulnerable sectors is keeping the germs to ourselves. Good hand hygiene, respiratory etiquette, cough into your sleeve. So again, looking at ways to break the chain. Then we've got the fourth link, which is how our germs get around, or we call that the mode of transmission. And so we move those germs from room to room, from floor to floor on our own hands. Those germs can be spread through coughing, sneezing, through droplets, and through air currents, which is why we've been talking a lot about air ventilation and filtration. Fifth link is the portal of entry and how those germs actually get into the new person. And so all of the mucous membranes that we're wanting us to cover and protect ourselves when we're dealing with potentially sick or truly sick people, they get in through our mouth, our eyes, cuts in the skin, unwashed hands, droplet contact with our eyes. So you may have sneezed, scratch your eyes. A lot of these infections are present and we give them to ourselves. You can also introduce germs by sharing things like drinks, cigarettes. And again, I know we talked about MRSA and certainly medical devices that enter our body, like a catheter. Also a potential way of breaking the skin. Sorry, I'm thinking of a needle in my head. We're not going to break the skin with a catheter, but certainly entering the body and potentially increasing our risk of getting the germ that way. And then finally, the sixth link is we need a susceptible host. And so that is the next sick person. So we do see a lot of our guidance target for vaccination for COVID, target the elderly, targets those that are immunocompromised, as well as infants who are unable to protect themselves. And so a lot of the measures that we put in place are out there to protect them as well. Okay, so that's kind of our job, is knowing that there's a germ and that it's hiding and that we do have vulnerable people that could be affected, and how can we break the chain to reduce their risk. So if you can turn that slide. Some people like a different type of visual, and so we're just going to dig in a little bit further. So if you can advance the slide page there. So again, we need that infectious agent. We'll move on to the next slide. We need the reservoir or the hiding place, and we talked about the examples being our skin, our personal devices that we probably carry with us all day, sometimes the food we eat, medical devices again, and sometimes pets can provide the reservoir for germs like rabies. Next slide. Again, some very visual examples of how germs leave our body: coughing, sneezing, blood, toilets, toilet use, as well as our hands. And again, lots of different ways that we can transmit, whether it's through droplets, touching, airborne, vehicles such as medication vials, improperly, whether we're using multi-dose vials, lots of different ways medications can be an issue, and then vector being ticks or mosquitoes. Again, how do we get these germs into our body? The infectious agent's way to get into the host: scratching our eyes, medical devices, the food we eat, and certainly kids who are in that mouthing stage when they're teething can introduce germs to themselves as well. And then finally, some examples that we talked about of having that susceptible person. Okay, so just reinforcing that with visuals. So using COVID as an example, this is this chain of infection, very simply put. So if you can advance the next slide, it will start to add to our diagram there. Yes, thank you. So our infection is coronavirus. And then our reservoir is the person infected with coronavirus. And then the portal of exit is the mouth, nose of the person who's infected by sneezing, coughing, spitting. The mode of transmission is through the droplets and contact, because droplets land on surfaces and we end up touching them. The portal of entry, believe it or not, these viruses, they do end up in our eyes, our nose, or our mouth if we don't protect ourselves. And then the susceptible host really is anyone. And I know we talked about the young and the old and those that are immunocompromised, but all of us who have never seen coronavirus before, before 2 years ago, and being unvaccinated, we certainly are at risk as well. So this is how this chain gets stronger, and we've got those 6 strong links. No, go ahead, Paige. And this red is ways that we can break these links. So the respiratory etiquette and masking, all of these measures that we keep discussing and guidance document keeps recommending. Physical distancing. We hadn't seen germs other than coronavirus over the last couple of years. Flu was, pretty non-existent, and we hadn't seen those other germs that cause our vulnerable outbreaks in our retirement home and congregate setting. And it's because we kept our distance. We stayed home, we isolated. Another way of protecting ourselves is to cover the eyes, nose, and mouth with our PPE. To perform hand hygiene often and properly, and to ensure that there's regular cleaning and disinfecting with a hospital grade disinfectant if we're dealing with an outbreak. And again, preventing it from getting into our body with good hand hygiene, especially before eating. I'm sorry, you're going to hear my phone ring until somebody hangs up. And then finally, another way to break the chain of infection is through immunization. And I know Dr. Tran, our medical officer of health, our chief medical officer of health of Ontario, as well as public health, we continue to promote the messaging of being up to date with our COVID-19 vaccinations to protect not only ourselves, but to protect others from the infection that we could potentially spread. Okay. And I will let Paige take over from me for here.
So as we just gave some other visuals and explanation about the chain of transmission and what we can do to protect ourselves and others, this pyramid diagram is another visual that can help put into perspective some of the super important things we can do to minimize transmission. So it's an example of the hierarchy of controls for prevention of infection. So at the top, we've got physical distancing, which everyone knows about after the past couple of years. So through physical distancing, we're breaking the mode of transmission link. We're doing this by ensuring that staff and clients maintain at least 2 meters or 6 feet of distance when it's practical on things like break or during social activities. Physical distancing is proven to be one of the most effective ways to reduce the spread of illness during an outbreak. Underneath physical distancing, we've got engineering controls. So these are things like physical barriers being put in place, such as in a dining room, having a piece of plexiglass in between clients so that when their mask is off and they're eating, they're unable to transmit germs to one another. Another example of an engineering control is having access to hand sanitizer dispensers for those 4 moments of hand hygiene. And then also improving air filtration using things like HEPA filters or fans that are pointed appropriately. Beneath engineering controls, we have administrative controls. So some of these are things like policies and procedures put in place by organizations to help prevent spread, things like vaccination rules or visitor restrictions. Another administrative control is education about transmission and education about what we can do to prevent the spread and keep ourselves and others safe. Signage is also an administrative control. So that's things like, how to put PPE on appropriately and reminders to stay distanced. And the last form at the bottom here we've got is personal protective equipment. So it's the last form of defense, and it's used in addition to these other controls and is very important for keeping yourself safe. The measures are less effective as we move down the pyramid, but they are equally important. So here's another visual for those of us who maybe were a little confused by the prior ones. This is the Swiss cheese model, and it is another approach to demonstrating the various public health measures that we can do to prevent disease transmission. And it explains how, or it shows how not only one layer of protection is perfect. Each has holes, such as the holes in the Swiss cheese. And when these holes align, the risk of infection increases. However, when we put several of these layers together and have more random holes in the more Swiss cheese slices we have along the way. So these slices could be things like social distancing or masking, hand washing, testing, contact tracing, all those kind of controls we talked about in the last slide. When we have or ventilation as well. When we combine these layers, we significantly reduce the overall risk of it reaching the susceptible host. Vaccination will also add another protective layer. And we continue to encourage colleagues, families, and clients to be up to date with their vaccines to ward off influenza, COVID-19, and the other vaccine preventable diseases that lurk in our environment. So now I'm going to talk about hand hygiene, as it is the simplest and easiest way of preventing the spread of infection and disease. So soap and water is used when hands are visibly soiled, and the soap and water will remove the majority of germs if washed appropriately and prevent the spread of infection. Liquid soap and not bar soap should be used in public settings, as germs can grow on bar soap and easily spread from one person to another. Paper towels should be used to dry hands. Alcohol-based hand rub is used when hands are visibly clean. Make sure that you apply enough alcohol-based hand rub so that it will remain in contact with the hands for a minimum of 15 seconds before the product becomes dry. This can usually be done with 1 or 2 pumps. Hand hygiene should be done for a minimum of 15 seconds, regardless of whether you're using liquid soap and water or alcohol-based hand rub. So now I'd like to ask the audience a question where you can enter your answer in the chat box. Which method of cleaning hands do you consider most effective at germ removal? I'll give everyone a minute there. And I'm not sure if Leslie, you're able to see the chat box. I'm not at the moment, so if there's anything in there you wouldn't mind reading aloud.
Thanks, Paige. I'll keep my eye on it.
So which do we think is more effective at germ removal? Washing your hands or using hand sanitizer?
We've got at least one person saying soap and water. Anybody else want to enter a guess? Washing hands. So I'm assuming that's soap and water as well. Somebody else is saying washing. Okay. Paige, I'll let you answer that one.
Thanks, Leslie. So evidence shows that the use of alcohol-based hand rub is as good, if not better, than hand washing with soap and water. Also, alcohol-based hand rub is faster, more convenient, and causes less skin irritation with repeated use due to the presence of emollients. 60 to 90% alcohol concentration is appropriate for use in congregate living settings. So the website for Public Health Ontario has a lot of great resources for IPAC, for visitors, for staff, for clients. So we're going to watch this 2-minute demonstration as a sample. They are doing the rubbing of their hands for a minimum of 15 seconds. And we like how it shows the first moment of hand hygiene where this worker is performing hand hygiene before they enter the client's room. So I hope we can see this. See how she's getting in between her fingers on the back of her hands. Her fingertips in the palm of each hand. Now she's getting her thumbs, and we can see how the hand sanitizer is still wet. Again, using the amount that will keep the hands wet for 15 seconds. And then I encourage each setting to view the full set of videos offered by Public Health Ontario on their website, including how to hand wash. Hands should be washed again, not using alcohol-based hand rub when the hands are visibly soiled. All right, so this signage that we've got here, again, another administrative control, was designed for use in healthcare. This one specific to long-term care. We have encouraged the use in settings outside of long-term care settings until there is something created specific to congregate living settings that everyone here today works in. So this signage is instructional and used when a client is in isolation under droplet contact precautions, being under those precautions because either they are symptomatic, have had a high-risk COVID exposure, or are a confirmed case of COVID-19. If this signage is present on the door, make sure that you stop and think about the personal protective equipment required for the interaction with the client in the room. And now we're going to talk about, or Leslie's going to talk about point of care risk assessment here. Oh, I think you're muted, Leslie.
I am. I turned my camera on and that was all I did. So thanks, Paige. You've learned a lot in the last 5 weeks. You're doing a great job. And these are exactly the things that we want to pass on to everybody. So conducting a point of care risk assessment. Everyone should be assessing the task, the resident, and the environment before they do any interactions. So these questions before us help form the basis of what is known as point of care risk assessment. By asking yourself these questions, you will be able to determine what type of PPE you will need to wear. So question number 1, will my hands be exposed to bodily fluids or contaminated items? Yes, so therefore I'm going to need to wear gloves. Will my face be exposed to a splash, spray, sneeze, or cough? Yes, so I'm going to ensure I'm wearing a well-fitted mask and eye protection. Will my clothes be exposed to splashes, sprays, or items contaminated with blood, secretions, or excretions? And if the answer is yes, you're going to protect your clothes with a gown. And does the client have any symptoms or a known infection? And if they do, you're going to follow specific additional precautions, which were in the signs that Paige just showed us. Okay, so we've got 4 scenarios here, and I just want to take a moment and go through them and see if they kind of speak to you and the things that your home, the services that you provide. So based on point of care risk assessment and organizational policies, we know right now that masking is universal. So we want to ensure that people are either wearing, depending on the policy, a well-fitted surgical mask, or depending on the situation or outbreak status, an N95. So scenario 1, if you have staff that are delivering a medication cup or a meal tray to a well person, not quite sure what would be delivering you know what, the meal tray would have come at the beginning of our recommendations when we would have an entire floor or an entire home isolated. And we know the new guidance is looking at isolating either a roommate, the ill person, and not someone who's well. But let's go with this scenario. So delivering a medication cup or a meal tray to a well person. Could somebody in the chat box let me know what PPE you should be wearing in this situation? Okay, I've got somebody saying a surgical mask, and that's correct. So there's no direct care being provided here. The interaction is likely going to be really brief and transient, and you're wearing the mask not because the person's infected, but because we're being told to at this state in where we're at in the pandemic. So excellent. So that's what's required. Thank you, Rachel. The 4 moments of hand hygiene should be practiced as well. So obviously before we enter the room, after we've delivered the tray, and before we leave, we're going to be providing the hand hygiene. So number 2, the high touch surface cleaning. So many of you working in congregate settings wear many hats. So not only are you, doing the screening and you're providing care, you potentially could be the one doing the cleaning. And what kind of protection are you going to use for high touch surface cleaning? That probably is once a day if you're not in outbreak, and maybe more often if you are. But just in general, in a non-outbreak situation, what protection are you wearing? Okay, I'm going to help you out with this one. So again, we know we're wearing our medical mask, and we're only doing this because it's universal masking. Outside of germs and COVID, we wouldn't be doing that. Um, and then you're likely going to be wearing gloves. A lot of staff worry about the products that they're using in hospital grade. Um, that would be the situation. Now, I know, just like everything, there's best practice and then there's what the home can manage. But when you're using something like a wipe to do your cleaning and disinfecting, there's no risk to the eyes. Um, if somebody's not using that for cleaning and disinfecting, we would hope that it's a pour bottle, pouring it into a microfiber cloth. I still see that homes have spray bottles, and it's not the best practice. Wouldn't encourage that to spray on a direct surface. One, it creates a bit of an occupational risk, and I would want my eyes protected in that situation, but it can get germs moving from the surface potentially into the air short term. So I wouldn't encourage that. And if I do see homes that still have spray bottles, I encourage them on their next purchase to switch it out to something else. But if they spray into the microfiber cloth and then then clean the surface, that's a better practice. And in that situation, I might wear eye protection, just knowing how big the nozzle is and how the spraying is. I would just hate for somebody to get that in their eye. So really in an easy situation here, it's the universal masking and the gloves. Hand hygiene before and after gloves are on. But again, if we're using something that could be sprayed into the air, I might use my eye protection in that situation. But again, this is all a personal risk assessment, depending on the product, depending on the situation, depending on whether we're in outbreak or not. All right, I know my screen has gone blank, but we'll roll with it. Scenario number 3.
The back, the screen?
So, no, it's good now. Yeah, you're good. So, some of you may provide direct care in the home that you're working in, and some of you may have contract staff coming in from care partners to do that kind of thing, the bathing or the showering. But what type of personal protective equipment should the staff be using providing that type of direct care? And as you're thinking through this, some of the questions you might be asking yourself are, how well do I know this client? How much assistance is going to be required for this task? How long is this task going to take? Might there be some splashing or spraying? And certainly some of those walk-in showers that I've seen, it's a pretty wet affair. And is the resident symptomatic? And we've certainly learned from this pandemic that those that are not feeling well in the days when they were isolating for 14 days, speaking with public health to know the safest way to ensure that everybody does get a shower or a bath, even during an outbreak, is really important. So I've got people saying mask, eye protection, gown, and gloves. And again, so doing your own personal risk assessment, we're wearing a mask, likely the eye protection because there's some splashing, and you're within 6 feet for probably more than 15 minutes. A gown because there's, soap products and water, and perhaps it'll protect and keep you a little drier underneath. And then again, gloves, depending on your policy. I know gloves can be cumbersome and get in the way. If your client happens to have scabies or skin lesions, or you yourself have had really dry skin from the weather and are concerned, that may be a situation where you're wearing gloves. And you may decide, I'm going to perform hand hygiene before I assist with the bath, and I will perform really great hand hygiene when I'm done, and gloves may not be required. But again, if your policy says something different, make sure you do know what that is and follow that. And then finally, scenario 4, something that we're all really excited about now that those indoor activities can resume. We can get together in small groups as long as the people are well. So if you're participating as a staff member in an indoor activity with a resident, what PPE are you now wearing? Again, you're going to be asking yourself, how close am I going to be to the resident or residents? Is anybody unwell in this situation? Can the resident or client understand instructions? Are they wearing masks? So if I'm thinking this is a small group of 4 people, we've got a really large room and we're in a circle and I know we're 6 feet apart and everybody is well and we've all performed our hand hygiene as we've come into the room, I might just wear a mask. Okay, hopefully that's helpful in going through the personal care risk assessment, which is a little bit different than contact droplet and that signage. And I always remind homes that that's what contact droplet means, that we've protected ourselves in those 4 ways, 5 including the hand hygiene. But if you do your own personal risk assessment, some of those may not be required in every situation. All right, we'll move on. Yes. So eye protection. Eye protection may be required when providing direct care or when within 2 meters of any resident with symptoms of illness. Always check your organizational policy. And so I think this one has been one of the guidance that we've been kind of keeping our eye on. It's flipped and it's flopped. Wear your eye protection universally, then don't wear it at all. And now, wear it only if they're symptomatic. So again, making sure that your home's organization or your organization has a policy in place, that it's up to date with the current guidance. And in all other circumstances, the use of eye protection should be based on the personal care risk assessment when you're within 2 meters of a resident. Eye protection is worn in addition to a mask to protect you from the potential spread of infectious droplets. And we talked about the eyes being a portal of entry. One thing that has changed with the guidance, initially, you just needed to protect your eyes. And we saw a lot of different products being used, safety glasses, mask shields. And team, correct me if I'm wrong, but I'm pretty sure the guidance right now is really encouraging goggles or full face shields. And whether your face shield is disposable or reusable, we're going to talk a little bit about that, but we do want to make sure that the membranes of the eyes are completely covered. I've seen lots of sporty type safety glasses out there that really don't cover a whole lot. The eye protection coverage from a shield, especially if you're in a shower, really is fairly complete. And then again, just promoting the Public Health Ontario website. They do have a document for how to clean and disinfect reusable eye protection. I can see this was last updated 2021. So they do still talk about what is reusable eye protection can include face shields, goggles, and safety glasses. And in most cases, safety glasses don't meet the mark. So take that with a grain of salt, but just ensure that there's a policy on how to do this, clean and disinfect if they are reusable, and that staff know how to protect themselves after they've cleaned it with good hand hygiene as well. All right. And we'll move past this one. Again, there are videos for everything that you can imagine on Public Health Ontario website, and including how to put on a medical mask and eye protection. So Paige, you're going to dive in a little bit more on the how to put on and how to take off our PPE.
Yeah, I'm going to play this video, another one from the Public Health Ontario website. So it's really important that you follow the correct order of putting on personal protective equipment, otherwise known as donning. You can remember that because the word on is in the word donning. So as we see, this worker is first performing hand hygiene before they don their PPE. And now the PPE that this worker is going to be putting on is to be used when you are providing direct care to a client. So this includes helping with feeding, helping bathe, changing clothing, or toileting. And that is the direct care definition from the updated guidelines from the ministry. So as we can see, she's first putting her gown on, tying up first the top, and then she will tie the second one to ensure that all of her clothing is protected. And notice again, she's donning before she enters the client's room, so in a clean environment. It's also away from where she will take off her PPE and dispose of it to avoid contamination. After the gown, she's putting on her combined eye protection with a mask, something we used to see more of at the beginning of the pandemic. However, now it's recommended that one wears a well-fitting surgical mask, as well as a face shield or goggles. And last but not least, she's putting on her gloves. And she's doing that before she enters the room. And here's just a visual to review the steps of putting on or donning PPE. This is a sign that should be visible with PPE at the point of use. And this is something that is looked for during IPAC walkthroughs, as per the Public Health Ontario checklist. And opposite of donning is doffing, or taking off PPE. And I'll just play a bit of this video as I explain. There is an extra step when it comes to doffing PPE. So it begins by first carefully removing the gloves, rolling one into the other, and dropping it into a hands-free waste receptacle. And when she is removing her gown, or when you remove your gown, which is the second thing you do, be careful not to contaminate yourself. You can do this by rolling it up away from you. And when she's rolling it up, she's keeping it also away from her clothes. So after the gloves and the gown have been removed, this extra step of performing hand hygiene is done. Very important before you remove your facial PPE so that you can keep your face protected and not transmit any germs. And unless your mask is visibly soiled or wet, you may choose to keep it on, since we are still universally masking, unless your organization has a policy that says otherwise. And after all of that's removed, again, she's performing hand hygiene. And again, here's a sign that should be on the outside of the room where you doff your PPE. So when it comes to glove use, there's often some practices that people do that aren't necessarily recommended. So gloves provide an extra barrier when in contact with blood and body fluids. However, 5% of gloves have micro tears, and these micro tears can increase the longer gloves are worn. This can allow microorganisms to contact the skin. When gloves are removed, the hands can become contaminated by the gloves as they are pulled off. Therefore, hands are considered contaminated even when gloves have been used. It's important that you're not double gloving and that you always perform hand hygiene before putting on gloves and after taking off gloves. Again, it's important that you never wear more than one pair of gloves at a time. Never apply hand sanitizer to gloves. It may break down the integrity of the gloves and doesn't allow for the friction necessary to kill the germs. Gloves are single use and task specific. For example, if you're providing morning care, a different pair of gloves should be used for assistance with brushing someone's teeth and a different pair of gloves used for them toileting. Never reuse gloves. Ensure gloves are removed prior to exiting the client's room and then perform hand hygiene. Prevent cross-contamination by removing gloves after attending to the task they were needed for. Perform hand hygiene and put on a new pair if personal care is required for the client's roommate.
Good. And just to finish up, I know you had said the donning is on the outside of the room in the clean area. You mentioned doffing outside of the patient's room, and I know you meant inside, if at all possible, which is usually the dirty, considered dirty. In some circumstances, it's not a good idea to have the doffing station in the client's room because sometimes intellectual delays mean that they may reuse it, get into it, and contaminate themselves. And some just are very helpful at helping with garbage and might contaminate themselves. So, or there may be space issues. So some homes do choose to have donning and doffing in the hallway, but we would just ensure that there's at least 6 feet between so that there is no cross contamination. So just wanted to clear that up. Finally, just wanting you to know that there's a number of IPAC resources out there to support you. I'm sure you're all familiar with the ministry's websites, the Government of Ontario, the MCCSS, and the Ministry of Health all have updates that are relevant to our practices. Southwestern Public Health, we have some IPAC experts. We have amazing infectious disease team members who can be available to answer your questions, as well as posters, resources, and workshops like today. The Southwest IPAC Hub provides community of practice opportunities, newsletters, and we do assist with the implementation of IPAC recommendations. IPAC Canada has some excellent webinars, excellent networking opportunities, and you can find a whole host of audit tools if that interests and meets the requirements of your site, as well as additional educational sessions. And again, I think we've promoted Public Health Ontario and all their resources fairly well today. With that being said, we've said a whole lot, and I don't know if there's any questions that have come out of any of the things we've talked about today. If you want to bring that up coming off mic or in the chat box, Kelly will help you ask those questions to us if needed.
Are all CLS considered high risk or no?
That is a great question, Danny, and something we've been trying to get some clarity from the Ministry of Health in the guidance document. So if we look at the, it's a bit difficult to figure that out. So at this point, we are saying that any of the congregate settings that meet the description of being a group home, a shelter, assisted with personal care, we are considering all of those considered a high risk setting. And that's because we do know that Public Health Ontario, their latest summary related to Omicron, does indicate that infectiousness, although shorter than the previous strain of COVID, although it's a bit shorter, people are still infectious, between 6 and 8 days after symptom onset or after testing positive if they did not have symptoms. So because of that infectiousness, the recommendation from public health is that staff follow the guidance for high-risk settings as far as return to work. If there's any changes related to how we, I would say please have some communication with your funder, whether that is a board or the Ministry of Community, Child, Community, and Social Services. Please have some conversations with them about whether your setting is considered a highest risk, but from the public health perspective, because the guidance for return to work, we want to take a more cautious approach so that if there is a staff member who is still contagious, they're not at risk of spreading it to residents. And because currently the guidelines for the community for return to work is 24 hours after symptom improvement. So for some people, that could be 48 hours after their symptom onset, which we know they could still be infectious. So we don't want to take that risk of having staff return to work too early. And certainly, as mentioned previously, there is the guidance available for those situations where there is a staffing crisis and you do need to bring staff back early, and to do that on a risk-based assessment, looking at bringing back the staff who, are closest to the 10 days first. I hope that helps to answer your question.
Thanks, Joanne. There's another question in the chat. I'm not sure, Joanne, if you want to take this or Leslie. The question is, the self-swab kits, are they to be replacing PCR tests for our staff, or only if PCR are not available?
So they are, so the self-swab kits is a molecular or a PCR kit. So it does need to go to the lab to be tested. And I know that I have heard that some staff are having difficulty getting a PCR test through an assessment center. Those kits could be used for staff as well as residents. So, it's the same kit. Certainly there is a video that demonstrates how to do a self-swab sample to get the best possible sample. We know that a nasopharyngeal sample is not something that you can do on yourself, or at least it would take a lot of maybe restraint, I guess you'd say, to be able to do an NP swab on yourself. So we know that that's the best way of sampling to get the most accurate result. However, using a throat and nasal swab is the next best way to get an accurate sample.
Okay. Another question. The guidelines talk about CLS, then highest risk. So it leads one to wonder. We have lots of CLS sites who live in a CLS site. So 3 or more people living together whose health is not considered high risk. The problem with bringing back staff early is that they have to only work with COVID positive residents. Often that isn't helpful to whole CLS. So yeah, when whole CLS isn't positive.
Yeah, so that is part of the risk assessment is, ideally if you have staff who've tested positive, that they return to work in an outbreak setting. However, that may not always be possible based on the staffing needs. And hopefully we'll get some more clearer guidance about highest risk. Whether the intention from the ministry was to provide a bit more definition from the higher source setting. And we're currently, seeking some more guidance regarding that. So as soon as we have anything more concrete about whether there is a difference, whether the intention was to define some as highest risk and some not, then we'll communicate that information out.